After her first son was born, the same songwriter I quoted this morning, Karen Pelletz, wrote, "My God, what a painful pain it was, like love." And right afterwards came a little man who erases previous memories. I think it sounds even better in Hebrew, but I'll save you the translation. Our next speaker is Professor Susan Ayers. Susan is a psychologist specializing in perinatal mental health. She leads the Center for Maternal and Child Health Research at the City University of London and is chair of the Society of Reproductive and Infant Psychology. Her research examines women's mental health during pregnancy and after birth, with a particular focus on anxiety and post-traumatic stress disorder. Susan is the author of Psychology for Medicine and editor of the Cambridge Handbook of Psychology, Health, and Medicine. She has been invited to give numerous lectures and workshops and was awarded the annual lecture prize of the Society of Reproductive and Infant Psychology in 2012. Her talk today is about birth trauma, risk, and resilience. Please welcome Professor Ayers.
Thank you for the nice introduction. Always makes me squirm a little bit. And thank you very much, Orit and Shirley, for inviting me to talk here today. It's a real honor to come to Israel for the very first time, so very exciting for me, and to be a part of this very interesting conference. So thank you. So I'm going to talk about what happens when birth is traumatic. Now, obviously, for most women and men, birth is a very positive experience, and it's the birth of their child. And most women will always remember the birth of their child or children throughout their life. It's a really important life event. When I first started doing research in this area, there really wasn't very much available. And so I think in tune with a lot of medicine, researchers focus very much on the risk for birth trauma. What makes birth traumatic? How many women are affected? More recently, I've become much more interested in the resilience, so it's really a pleasure to hear Mike talk this morning. I'm not an expert in the field, and there's very little that's looked at resilience in relation to birth trauma, so we have to draw on the broader literature. So I'm going to give you an overview of PTSD, both in pregnancy and after birth. But I want to start by saying that the events of pregnancy and birth... Oh, okay. Is that better? Okay, sorry. So the events of pregnancy and birth can be stressful. The complications can arise. And these events there can be also psychosocial difficulties and adverse circumstances. And these can be stressful, so they can either exacerbate existing mental health problems or they can trigger new mental health problems. And these complications can also be traumatic in a small proportion of people, so we still do have maternal mortality, thankfully very, very reduced in developing countries. And we also have maternal morbidity and also problems with the infant when the infant's born potentially preterm or stillborn. What I should say really up front is that a woman's subjective experiences are more important than the obstetric complications. So yes, women who have severe obstetric complications are at greater risk of finding birth traumatic, but not all women who have these complications will develop PTSD, which comes back to the resilience factor. And the other really important thread that will come through my talk, and it was really great, Yale, that you brought that into your talk, is that support that women receive during birth is absolutely critical, and it can buffer against the negative consequences of a stressful or traumatic birth. So this is an event where we, as healthcare professionals, can make a substantial difference to parents' experiences and emotional well-being. Before I go on to talk about PTSD, I just want to show you this slide. It's from Catherine Grant, who developed puerperal psychosis after the birth of her first son, and she is now an advocate for women who develop psychosis. But this is her slide that says, unbeknown to us, the perfect storm of risk factors had gathered. And she talks about part of that being a traumatic labour, also that she had an unknown family history of bipolar disorder, She'd had previous episodes of depression. She had sleep deprivation. She had a postpartum infection and fever, worries over breastfeeding, and within 24 hours she developed severe psychosis. She actually went catatonic, completely catatonic, for a number of hours. And then she had a variable course. And the reason I put that up is I'm going to be talking about post-traumatic stress disorder, but I think it's important to realise that a traumatic birth can be one part of a whole host of factors that can trigger not just PTSD, but also other problems. Okay, so what does the literature tell us about PTSD in pregnancy? Obviously, there'll be women who come into pregnancy already with post-traumatic stress disorder or with a history of trauma and abuse. And there have been 2 reviews and meta-analyses that suggest that around 3 or 4% of pregnant women will have PTSD already. But if we look at high-risk women, such as those who have a history of child sexual abuse, it can be up to 39%. So we really should be picking up these women in pregnancy. The majority of these women, however, are not identified by services, and the research suggests this may be as high as 75% of women in these high-risk groups not being picked up. And PTSD in pregnancy is associated with adverse outcomes of preterm birth and of low birth weight. The 2 are probably associated. And possible pathways that have been put forward by Julia Seng, who's written quite extensively on this topic, are increased or dysregulated psychophysiological stress responses and risky health behaviours such as substance misuse. And I think the importance of PTSD in pregnancy is also underscored by what Martin was talking about, which is these developmental origins of health and disease. So back in the 1990s, many of you might be familiar with the Barker hypothesis. David Barker was an epidemiologist in the UK, and he hypothesized that actually women's nutrition during pregnancy, and in particular the baby's birth weight, were really critical in that baby's then later risk of cardiovascular and metabolic diseases in middle age, older age. And there's now quite substantial epidemiological evidence supporting this. Well, that's about nutrition in pregnancy. We can kind of get that. But now we know through the sort of work in looking at the fetal programming hypothesis that women's emotions during pregnancy can also affect the fetus, in particular stress and anxiety. So there's been, for example, a study in Canada, the Project Ice Storm. I don't know if you're familiar with it, when they had the ice storm in Quebec, and they followed up women who were pregnant during that ice storm. And they followed them up now for a number of years. The teenagers are now adolescents. And that project has shown, along with many other projects, that stress in pregnancy is associated with a greater risk of a range of adverse outcomes. So, for example, the baby being rated as more fussy, poorer child development, and metabolic changes. And then if we look at the PTSD literature, we also have evidence that there can be intergenerational transmission of vulnerability to trauma, observed in, for example, people who went through the Holocaust and their offspring. So we see this intergenerational transmission of vulnerability, and it's likely to be influenced by both epigenetic processes, as Mike alluded to this morning, and also by potentially parenting, differences in parenting and environmental factors. Project Ice Storm also, one of their analyses, looked at how stress was appraised during pregnancy and found that, this is just one example, that women who appraised the ice storm negatively, as opposed to it being neutral or positive, that was associated with changes in their adolescent children's DNA methylation in over 2,000 sites, associated with over 400 biological pathways. So that's just one example of the epigenetic mechanisms potentially. Okay, so that's pregnancy. That's women who come into pregnancy with PTSD. What about when women develop PTSD as a response to a traumatic birth? So the reviews and meta-analyses suggest that in addition to women who have PTSD in pregnancy, a further 4% of women will develop PTSD in relation to what happens to them during birth. And in terms of the EU, I'm sorry I didn't calculate this statistic for Israel, but in terms of the EU, that means approximately 204,000 women will be affected every year. And if it's simple PTSD, if a woman doesn't have a complex history or adverse social circumstances, it's remarkably easy to treat. So it does beg the question, why are we not trying to pick it up? So symptoms of PTSD, and I use the DSM-4 criteria here because the DSM-5 criteria are somewhat controversial, partly, but also most of the research that's been done in this area has used the DSM-4. So according to the DSM-4, symptoms of PTSD arise, first of all, when a person has been through a traumatic stressor. And in order for a stressor to be classified as traumatic, the person has to think at some point during that event that they, or in the case of birth, their baby is going to die or be physically injured, and they have to respond to that with intense fear, helplessness, or horror. There are 3 symptom clusters with PTSD. The first cluster are re-experiencing symptoms, so things like nightmares, flashbacks. Then avoidance symptoms, which is trying to avoid any reminder of the birth, and that may be primary reminders, such as avoiding returning to the hospital, or it may be secondary, such as TV programs, hearing ambulance sirens, and so on. And then also hyperarousal symptoms, which is increased vigilance, but also irritability and anger in some cases. It has to have lasted for more than 1 month, and it has to cause people significant disability and impairment. So the largest study that we've had done in the UK so far suggests that approximately 20% of women fulfill criterion A for a traumatic birth. That's 1 in 5 women. That's high. And actually, in Australia, the prevalence of fulfilling criterion A is even higher again. In reviews and meta-analyses, it shows that in community samples, between 3 and 4% of women develop PTSD as a result of birth. And in high-risk groups, again, we see an increased prevalence of 15 to 18% of women developing PTSD. So this may be women who have, for example, preeclampsia or postpartum hemorrhages. Okay. So we know a lot about PTSD from studies of military veterans, and that's fantastic. We've really, the research funding has been there and the support has been there, and we know a lot about it. I want to ask you a question. What do you think affects more people? PTSD in military veterans or after birth? So the prevalence of PTSD in military veterans is between 10 and 13%. I found a nice paper that told me exactly how many estimated exactly how many UK veterans there were, 3.7 million. The prevalence of PTSD in women after birth is 4%. And the UK, well, I had to work this out by taking the UK population of women and then reducing it to those who would have been of childbearing age at some point, and then also reducing it by childlessness. So that's my estimate. So what do you think? Okay, I'll show you. So actually, in terms of sheer numbers of people affected, PTSD as a result of birth is affecting more women than it is affecting veterans. And as I said, it's remarkably easy to treat. There are some unique aspects of postnatal PTSD. So culturally, obviously, childbirth is perceived as positive. So women who experience childbirth as traumatic and have post-traumatic stress disorder can find it very difficult to talk about in that context of culturally this is a positive thing. Very often, the focus is on, well, you've got a healthy baby, therefore you should be fine. And the women may be very grateful they've got a healthy baby, but they are not fine. There's also the potential for the connection or disconnection of the baby with the traumatic birth. So if a woman connects the baby with the trauma of what happened to her, she may want to avoid contact with the baby. So there are case studies where women will avoid all contact. In the studies we've done, women actually talk more about knowing what they're supposed to do, so they go through the motions, but they'd rather not, and they don't feel that connection with the baby. That's not all women. So some women do not connect the baby with the trauma, and they bond with their baby very well. So I don't want to say that all women are like that. So there's a potential for two people to be at risk, both the mother and the baby. And the other point to make is that healthcare professionals and also healthcare places are often associated with the trauma. So I used to run a clinic as part of an obstetrics department, and my treatment room was right next to the delivery suite. So if I was seeing a woman for a traumatic birth, first of all, a lot of them didn't turn up because they'd get to the car park and they'd be in such a state of anxiety they couldn't come in. And secondly, if they did turn up, I knew I had to be waiting for them to sort of usher them straight into the room and try and manage their anxiety levels, which would be very high. The other thing is that expectations and desire to have more children force women back to the trauma. So I saw one woman clinically who was very interesting. She'd had a first child and she'd had a very severe postpartum hemorrhage. So she'd spent time on the high dependency unit. And she was now pregnant with her second child. And she said to me, "It's as if I've had an awful car crash that was really traumatic, and you're asking me to get into the same car and drive the same journey, knowing the same crash is going to happen." And I thought that was a very good way of articulating it. And I have also interviewed women who've decided not to have more children because they cannot face the idea of revisiting, of going back and going through childbirth again. The other point to raise is that symptoms are complicated by normal postnatal factors. So, for example, there's evidence coming out of the general PTSD literature that insomnia, that sleep problems, insomnia, is associated with a more chronic course of PTSD. Well, when in your life are you ever going to have less sleep than when you've got a new baby? So there's that, so we need to be aware, mindful of the fact that normal postnatal factors may inflate PTSD. In terms of the impact, there's evidence that there's qualitative evidence that it has an impact on the woman, and if I have time, I'll give you some examples of this later, such as fear of subsequent pregnancies, or secondary tocophobia, as it's sometimes referred to, sexual avoidance. So one woman was really funny. In an interview, I remember she was really emphatic. She said, "I am not having sex because there is no contraception that convinces me I'm not going to get pregnant." Which was, it was quite said in a funny and very emphatic way. But later in the interview, she actually really started crying and said, "I love my husband very much. I cannot be a wife to him in that physically intimate sense, and I think I should leave him so that he has the possibility to have that with somebody else." Yes. So sexual dysfunction is very common, and then obviously psychological ill health. Unsurprisingly, there's an impact on the couple, and again, this is mostly qualitative work that's been done that shows relationship strain and marital breakdown, and I'll hopefully give some examples later. And there's a few studies now coming out. This is still an area where we need much more research, but the few studies that have come out suggest it does also have an impact on the infant and the child. So there was a large cohort study in Norway that showed lower rates of breastfeeding in women who had PTSD symptoms, and also poorer cognitive, social and emotional development at age 2. So what makes birth traumatic? Okay. Well, in trying to answer this question, we can draw on theory and evidence to understand the causes of PTSD. There have been a couple of models of postnatal PTSD put forward. I think to call them theories would be one of them is by Pauline Slade. It's very eloquent. It looks at what factors may be predisposing, precipitating and maintaining factors. And then my team and I used the vulnerability stress or diathesis stress framework to try and summarize the evidence around risk. In terms of the theories of PTSD, I think the two I'd like to flag up are Horowitz's theory of traumatic stress responses. Horowitz argued that when we go through a traumatic event, it's so outside our realm of experience that we go into sort of denial, shock and denial first of all, but then that our brain will sort of prompt us to process this experience because we're driven to process and then emotionally file the experience. And so the symptoms of re-experiencing, like intrusions, nightmares, are our brain's way of prompting us to start processing that experience. When we become too emotionally overwhelmed, we then go into the avoidance symptoms of avoidance and emotional numbing. And Horowitz argued that this oscillation between these two was actually an adaptive way for us to slowly process what has happened to us without becoming emotionally overwhelmed. And the reason I flag that up is because actually the literature more broadly does show that a lot of people who have traumatic stress symptoms immediately after a traumatic stressor will recover spontaneously over the first 3 months, which also links to resilience. And so what we mustn't do is pathologize those early stress responses. The other one I'd like to flag up is the Charavastra and Cloytra social model, because they look at how interpersonal social factors are important in trauma. So for example, if people go through a traumatic event where another person is perceived to be trying to harm them, they're more at risk of developing PTSD than if it's a non-interpersonal event, such as natural disaster. And they also, as a part of that, look at attachment styles and the influence of that on PTSD. So this is this is the example of the diathesis stress or vulnerability stress framework that we use to try and just give an easy summary or overview of the types of vulnerability and risk factors that might be important. So things like depression in pregnancy, fear of childbirth, a history of trauma or PTSD, and obstetric complications in pregnancy such as preeclampsia will interact with what happens during birth. So as I said earlier, negative birth experiences are key, but then if women do have operative births, and by that I mean cesarean sections or assisted vaginal births, they're more at risk. If they have poor support during birth and if they dissociate, and the dissociation and the poor support and the operative birth, which in a way is a proxy measure of exposure, potentially, that's very consistent with the PTSD literature generally. And then postnatally, PTSD is highly comorbid with depression, and again that's very consistent with the general literature, and poor coping and stress may prevent the natural resolution of symptoms, and mean that women are more likely to go on and develop chronic PTSD. The evidence supports this, so there have been 2 reviews and meta-analyses supporting these key vulnerability, risk and postnatal factors which fit with the previous framework, so I won't go over them again. The qualitative literature is also quite complementary, so there's been a meta-synthesis of the qualitative studies of traumatic birth, and the first 4 are very consistent in a way with the whole experience of birth, so feeling invisible and out of control, feeling trapped in this recurring nightmare of childbirth, being treated inhumanely, which comes back to the support, experiencing this roller coaster of emotions. But there's also the final 2, which are more about the relationships and about growth, actually. So first about the disrupted relationship, so the impact on the relationship with the baby and with the partner, but then also finding a strength of purpose, finding a way to succeed as a mother despite these difficult and unwelcome beginnings. So that comes back to the sort of resilience and growth aspect. So when we're in crisis, we have the anxiety, intrusive thoughts, flashbacks, and so on, and hopelessness. Resilience is when we have adaptation in the context of past or present adversity, where we can persist in the face of challenges or bounce back. Then we have another aspect, which is sort of the next level again, which is growth. And that's experiencing positive change as a result of a crisis and the experience. So it's beyond effective coping. It's about actually positive change. So what factors are associated with resilience? This is a review taken from the literature on resilience generally. So this isn't, so we have very little research looking at perinatally. And you can see in adulthood, the review concluded that psychosocial factors associated with resilience are things like positive emotions, optimism, active coping, cognitive reappraisals, altruism, mastery, social support, facing fears, and finding meaning and a sense of purpose in what had happened. And I think it's really interesting to consider the risk and the resilience factors, because if you focus on just one side, you don't get the whole picture. And I think it's also interesting to think about resilience factors in relation to what we do in maternity services, because actually if we think about interventions from a resilience point of view, we may think very differently compared to if we think from a risk point of view, and I'll come back to that later. This is one study that's been done just looking at the proportion of women who were resilient after a traumatic birth. So this was a large study, a cohort study in Turkey of just under 1,000 women. And of those 1,000 women, 226 had a traumatic birth as per DSM-4, stressor criterion. And PTSD was looked at 4 to 6 weeks and 6 months postpartum. So a number of things came out of this. First and foremost, most women were resilient. So 62% of women in this study had had a traumatic birth as per DSM-4 stressor criterion, but did not have were not a case of PTSD. And in fact, you can see them at the bottom. Their mean symptom levels are around 5, so very low. You can also see that 14% of women had chronic PTSD, and they're the bar actually at the top. So they're also the women who had the most severe symptoms after birth. And then you have these interesting groups, first of women who had high PTSD at 4 to 6 weeks, but then spontaneously recovered by 6 months, and that was 18% of women. But then you also get this group of women who have delayed PTSD, and that was 6%, and that's actually consistent with another study we've done, which we've not published yet. So around 6% of women will not have very high symptoms at 4 to 6 weeks, around 10, but by 6 months they fulfill diagnostic criteria for PTSD. And when we looked at factors that were associated with, that differentiated between women in the resilient group and other women, we found that women in the resilient group had more support, less fear of birth, greater satisfaction with health professionals, and less anxiety and depression. And you may be interested, if you work in OBGYN, to know that women with delayed PTSD were more likely to have had emergency caesarean births, preterm births, or further traumatic events after birth. So it may be, and this is speculation, but it may be that physical complications either with themselves or with the baby or additional traumatic events prevent any sort of natural recovery and just increase the allostatic load on these women. And what about growth? Again, there's not been a lot of work in this area. Growth is experiencing positive changes in beliefs or functioning as a result of highly challenging life events or circumstances. And in the studies that have been done, they suggest that the majority of women, and this is a community sample, so not women necessarily who experience traumatic birth, around over 50% of women report some positive growth after traumatic or difficult births. Sorry, the study was after traumatic or difficult births. So 68% reported appreciation of life, 52% personal strength, 51% changes in relating to others, and then also new possibilities and spiritual change. This was conducted in the UK. In terms of factors associated with growth after birth, there haven't been very many studies, so I've tried to pull out those factors that have been found in a number of studies, and Orit's work has been a large part of this area. So younger age, women who are younger report more growth. Lower level of education, women who are having their first baby, women who have operative births, preterm births or multiple births, and also women who have approach coping styles or who have had PTSD in pregnancy report more growth. However, a caveat is that there are cross-cultural differences that are evident, and so I'm not sure how generalizable this is across different cultures. So now I want to look at the importance of support, because that's where we can make the difference. If you work in OBGYN, this is where we can make, or midwifery, this is where we can make a difference. Now that's not what you expected. Okay, this is my daughter jumping out of a plane. She's a midwife. She was training to be a midwife, so she wanted to raise money for obstetric aid in Africa. So she decided she'd do that by jumping out of a plane. My daughter is terrified of heights. She's so terrified of heights, she won't even stand on a chair to get something from a cupboard. So you can imagine when she was, in the 3 months coming up to doing jumping out of a plane, she was incredibly anxious, and I had to do an awful lot of motherly reassurance saying, don't worry, darling, it'll be fine. Statistically, your chances are really low, which didn't help at all. So when she got to the airfield, I think they could see she was white and very anxious. So they paired her with a really experienced instructor who taught her, said, don't worry, I've done this many times before. You will be fine. Just listen to me, do what I say, follow my instructions, it'll be fine. So there they are. He said to her, look up and just breathe. And he's checking the ground. And you've seen that one. There they are coming out of the plane. And there she is. She loved it. And there she is, a bit more relaxed again. She came home. She said, Mum, it was great. I want to do it again. I'm like, oh, no. She did it with a very good friend of hers, who's very confident, not frightened of heights at all, was really excited about the idea of doing a skydive, was very good with my daughter through the whole 3-month lead up at sort of keeping her calm. And so when Amy got to the airfield, they paired her up with another instructor who I don't think was intentionally malicious. I think he was a bit of a joker. And so when Amy went to meet him, the first thing he said to her was, stay close to me because I've got the parachute and you haven't. So that wasn't a good start. And then he just joked with her all the way up on the plane about, falling out of the plane and the parachute not opening. And there she is. She was terrified. She screamed all the way down. There she is. It's almost primal. And then he screamed too. You can see he's still joking. Now, why do I tell this story? I think this story is just a really good example of some things that are really important. Jumping out of a plane, like giving birth to a child, is a challenging thing to do. We all come to that with very different backgrounds, with very different feelings and expectations. But what it also shows is that when you're going through that, the actions of others around you are really important in how you experience that event, particularly when they're the people you're trusting to keep you safe. And so I think it's a good analogy to the importance of support during birth. And Yale mentioned the hotspot study that we did. We asked women who self-identified as having had a difficult traumatic birth to tell us about their hotspots, their moments of peak distress during birth. And first of all, we see that when we looked at whether the women fulfilled DSM stressor criteria for birth being traumatic, but didn't have full PTSD, compared to women who had traumatic births and had full PTSD, we see, an increasing number of hotspots, which is consistent with the PTSD literature. Generally, and also the number of hotspots women are reporting is fairly consistent. This is 650 women. And then we asked them to write what happened during this peak moment of distress. And we analysed what they wrote for the themes that were coming out. And the first two were not surprising. We got obstetric complications, so obstetric intervention or pain, 36% of worst hotspots. And then the next, infant-related events, complications with the baby, being separated from the baby, were common themes. But what really struck us is this final category here, which is a large category, and it was all around interpersonal events or difficulties. So women describing being ignored, not being supported, poor communication, feeling abandoned or put under pressure. And this is very consistent with Charivastra and Cloitra's argument about social aspects of PTSD. And when we looked at the levels of symptoms in these different groups, the women who reported hotspots around interpersonal events had the highest level of symptoms. Okay. So the actions of others during stressful events are critical in how we feel and respond. And there's plenty of research evidence showing that continuous support during labour is important in birth outcomes and in the quality of the birth experience. So there's an excellent Cochrane review on continuous support in labour for those of you interested. We also see that it can buffer against traumatic birth events, and that interpersonal trauma, such as the difficulties during birth, are more likely to lead to PTSD. And prospective studies show that this support is particularly important for vulnerable women, so women who have previous histories of trauma or abuse, or who have complications and interventions during birth. So how do we go about reducing risk and increasing resilience? This was a nice study done in the Netherlands. It was an online survey asking women who had traumatic births, what healthcare professionals could have done to prevent it. And I know the authors of this study, and they said they put it online expecting a few hundred women to respond. They had 2,000 women within 10 days. That in itself says these women really want their voices to be heard. And the most common responses were better communication or explanation, listening to the women more, supporting them more better, either emotionally or practically. So again, emphasising the importance of support. So how do we pull this all together in terms of thinking about maternity services? This is really just a few ideas that I've put into a slide. I'm sure there are many more possibilities. So in terms of reducing risk of birth trauma, we could screen for vulnerability in pregnancy. And there's a group in the Netherlands who are doing some excellent work on that as well. There's a trust in the UK where they have a system where they actually highlight the maternity notes of women who are vulnerable. So if women are vulnerable and they're seeing a psychologist during pregnancy, their notes will have a flag on so that everybody dealing with that woman will know that there is a vulnerability there, and there will be information inside the notes about how healthcare professionals can help this woman during pregnancy and birth in terms of reducing risk. So it may be as simple, for example, just checking I've got time to give you a quick example. So for example, I saw a woman as part of one of our research studies who had been quite violently raped as a young woman. She was now in her early 30s and happily married, and she was pregnant with a wanted pregnancy. It didn't occur to her to think about the rape. Then she went into labour. She was doing very well at home. She went to hospital when she was in established labour, and then when she got into the hospital, the first thing that happened was obviously she had to strip off and put the robe on, and then she had an internal examination, which was very painful and which was done by a male doctor. And as soon as that happened, she flashed back to the rape. And then from there on, her birth, she said it wasn't about the birth, it was about a rape. And she disconnected she said it's like I went to hospital, had a car crash and came out the other side with the baby. So she bonded with the baby fine, but she had PTSD. So something like that could be avoided if it's known about in pregnancy, and in the notes you can say, please avoid all unnecessary internal examinations, don't use assisted vaginal deliveries if assistance is necessary, and make sure if internal examinations are absolutely necessary, they're done by a woman. That could have prevented all of that. In birth, we can support vulnerable and at-risk women, or we can reduce or tailor intervention, but like I've just described. Postnatally, we can screen for psychological problems, and we can provide early intervention. So in the UK, we have, midwife debriefing is probably a bit of a misnomer, but women can go back to the hospital and can talk to a midwife with their birth notes and talk about their birth and get information about why things were done, why things were necessary, but also talk about their own emotional response to birth. And then if they do have PTSD, the recommended treatments in the UK are cognitive behaviour therapy or eye movement desensitisation and reprocessing. We also need to feed back into services through things like audit and efficacy, specialist training and service development. So I wish I could have moved my treatment room from right outside delivery suite to somewhere safer for women. And then, as I was saying earlier, it's quite interesting to flip this. So again, this is just me thinking up. If we flip it and we think, what can we do to increase resilience to birth trauma, then we start to think about slightly different things, like coping skills for birth, or increasing self-efficacy, like you said, Heidi, or focusing on personal strengths, positive emotions, meaning, and reducing perceived threat. We might focus more on positive emotions during birth, on strengths and meaning. So if we look at postnatal, I was talking with someone recently who was running what he called circles of reflection after birth, which were all about making meaning of the birth and becoming a mother in a sort of support group setting. We might look at garnering more family and community support at reappraisals, emotion regulation, and again, feedback into services, I think is so important. So I just want to end with women's voices, actually, because I think I can talk for hours about this topic, but I know you all want lunch. So, but I think it's women's voices that really bring it alive. And Cheryl Beck, who's a professor of nursing in North America, has a wonderful term of the ripple effect of birth trauma, in that it doesn't just affect the woman, it then affects the baby, the couple's relationship, and their future reproductive choices. And certainly, so this is one study, a qualitative of couples who'd, where the birth had been experienced as traumatic. And here are some quotes. So these are the themes. So the impact on the relationship, a woman said, "When I was suffering with PTSD, it dominated my life, and therefore by extension our lives totally. There isn't room for anything else in a relationship when you're going through that." And then physical relationship, I alluded to that earlier. A woman said, "I think when you've been violated to that extent, you don't ever want to be touched by anybody ever again." There'd be difficulties in communication. Men in particular talked about feeling abandoned or rejected. So one man said it can make you feel unsure if you're kind of wanted or needed in the relationship. But also then this positive theme of coping together. So one woman said, if he hadn't been there at the birth, how would I have explained what happened to me? Because you just can't explain the horror of that unless you were there. So for her, the fact that he was there and could validate what had happened, what they'd experienced as a couple, was important. And then finally, some of the qualitative, a qualitative study on the impact on the parent-baby relationship. So what happens during birth can impact on how people perceive their baby. So one woman said, "She wasn't ready to come out, and it just made me think she is really angry. I just think the whole thing was so unnatural that it created an unnatural child." It's quite a strong perception to have of your child immediately after birth. And similarly, this second quote is from a woman who connected the baby with the trauma. So as I said, this isn't always the case, but this woman said, "I can remember thinking, you horrible thing, you've done this to me, you evil child." So it does have an impact on their relationship with the baby. Most women say they know what to do and they will do it, but the emotional bond develops more slowly. So one woman said, "I hate the bond word. I didn't bond with her. I didn't particularly want to go near her. I'd go near her, but I wouldn't touch her." But we have to remember that this is also in the context of the family. So dads, some dads will see this and will compensate. So this dad said, I know I did try to direct a lot of attention and love to the baby because I felt maybe my wife wasn't providing that. So I was trying to bridge a bit of a gap. So, we need to be looking at the family unit. Some women, instead of wanting to avoid their baby, would become almost over-anxiously attached. So this woman said, I think it's made me so overprotective of her, I don't let her out of my sight, and I don't like other people touching her, which of course can also have implications in terms of parenting. So in summary, I just sum up. Evidence from the UK suggests that around 1 in 5 women experience birth as traumatic. 4% of women have PTSD in pregnancy, and a further 4% of women develop PTSD as a result of traumatic birth. However, most women who have a traumatic birth are resilient and do not develop PTSD. And we have information on risk factors for postpartum PTSD. We have less information on resilience at the moment. We still need more research, but we can draw on the general literature. We can see absolutely that support and care during pregnancy, birth, and postpartum are important in both risk and resilience, so we need to use this to prevent PTSD and enhance positive outcomes. Thank you.
Thank you very much. I don't want to miss the chance to have, so just one question, please.
And then lunch.
And then lunch. Yes, Steve, please.
I noted on some of your slides, I believe that you used the word dissociation, and you were talking about dissociation as a symptom or a sign of vulnerability, I think. Could you just talk about how dissociation plays into your research and to the experience of the women that you work with?
So I haven't studied dissociation quantitatively. This comes out of a research group in the Netherlands who've looked at it in much more detail. And their studies show that women who have high levels of dissociation during labour and birth are at greater risk of developing PTSD symptoms postnatally. In terms of how it manifests itself, in the qualitative studies we've done, women describe a whole range of different types of dissociative responses. So not feeling like themselves, or feeling out of themselves, or feeling like, these are just examples that I can think of, or feeling like they're looking at the world through, a screen somehow. Yeah, so that's qualitatively how women describe it to us. Yeah. Okay.
Thank you again.
Thank you.